Welcome to Caring for Patients with Down Syndrome, a professional development series for health providers, brought to you by the Down Syndrome Association of Greater St. Louis and the Global Down Syndrome Foundation. This lesson, Sexual and Reproductive Health Care in Adults with Intellectual and Developmental Disabilities, features Dr. Anjani Urban.
I'm Dr. Anjani Urban. I'm an assistant professor in the Department of Family and Community Medicine at St. Louis University School of Medicine. And I am happy to be here today to talk to you about sexual and reproductive health and health care in adults with intellectual and developmental disabilities. One of the quotes that I have found to be just so profound is from the WHO, and they said that sexuality is a central aspect of being human throughout life. And this is a truth regardless of whether a patient has intellectual, developmental disabilities, or they're considered sort of neurocognitively not having any kind of impairment. All human beings are sexual human beings. The problem for our patients with intellectual and developmental disabilities is that they're often assumed to be asexual. They are often assumed not to have sexual feelings. They're given inadequate or, if any, sexual education, and this puts them at risk for so many problems. They are at a higher risk for sexual abuse. They're at a higher risk for unwanted social and sexual behaviors. They're at a higher risk to getting barriers to appropriate health care. And quite frankly, even society systematically ignores the fact that these patients do develop sexual relationships, and those relationships are even systematically discouraged by society. An example of this would be what we consider the Medicaid marriage penalty. When two patients with various disabilities are both getting Medicaid, they are discouraged from getting married because that would put their combined income higher than the threshold of what would qualify them for Medicaid. So there are so many places that we can do better to take care of our patients in this particular aspect of their health. What are some of the areas in which we as healthcare providers are missing opportunities to take care of our patients? Number one, we simply don't have enough physicians trained in the care of patients with intellectual and developmental disabilities, and that is part of the reason why we are making this video series. Physicians often are poorly cognizant of what patient concerns may be in this particular realm. Oftentimes, patient autonomy is not recognized. Just because a patient has any kind of intellectual disability or developmental disability does not mean that their family members or caregivers are privy to their private health information. And they may not feel comfortable talking about sexual topics with their doctor if they have a caregiver with them. Sometimes we have poorly designed spaces for our patients. We have exam tables that are not convenient for patients who are wheelchair bound. We have exam rooms that are uncomfortable for people who have sensory issues. So these poorly designed spaces also make it difficult to provide appropriate health care. And then in addition to that, we may have patients that need extra time to prepare for appropriate physical examinations. They may need extra coaching. They may need to have certain accommodations in the room in order for us to be able to do an appropriate examination. And just due to lack of awareness, there are many missed cancer screenings that many of our patients don't get. And all of this in total results in a poor life expectancy and poor quality of life for our patients with IDD. And this is a missed opportunity that is unnecessary because it can be easily remedied. When we are trying to provide good quality care for the sexual health of our patients, the first step is to be proactive in sexual health education. So there are a number of things we want to consider when we're having these discussions with our patients. And number one, make sure that the discussion is age appropriate. What you may discuss with a 8-year-old is going to be very different than what you would discuss with a 16-year-old versus a 25-year-old. So it needs to be age appropriate. It needs to be clear and direct. Use of euphemisms for body parts is discouraged. Be clear, and if needed, use diagrams. You may want to consider the need for a patient to have a caregiver available to help explain topics or help communicate with the patient if that is needed. That, of course, will be dependent on the patient's level of autonomy. When you're talking with patients, you want to make sure that you are using repetitive and clear, sometimes visual diagrams, but sometimes it may involve using somebody else who has more time to provide this education. So there are actually sex health education coaches that are available in the community that can help go into more depth with these topics with our patients. There are some great resources available to the public. One resource that I love is a website called Project Shine, and it is by the Planned Parenthood of Greater New York. And it provides excellent videos and excellent websites with information for our patients with intellectual and developmental disabilities and their sexual health in many aspects of their sexual health. There's also a podcast called Low Down, which also talks about many of these topics. Not all of this education needs to be direct from the provider, but it is important that the provider is aware of the resources out there and has a basic understanding of how to address these needs with our patients. The cross-section of intellectual developmental disabilities with gender identity and with sexual orientation actually has a lot of overlap. And this is a topic that we need to feel comfortable in addressing with our patients. We want to make sure that we have discussions with them about what is sex? Mechanically, how does it work? Make sure they understand that, but also they need to understand some of the social constructs such as consent, also safety. Making sure that patients understand about how reproduction and pregnancy works. Many of our patients may be interested in procreating, and we need to be able to give them appropriate guidance as to how they can achieve this if it's wanted or desired, or how they can avoid it if it is not wanted or desired. And so we also want to feel comfortable talking about contraception and sexually transmitted infections. In terms of menstruation management, this is definitely a topic that can be a little bit fraught. It can be quite a stressful period of time for both the patient and possibly their caregivers. So anticipatory guidance in the premenarchal phase is very important. Again, it needs to be cognitively appropriate. And then it also needs to respect privacy, autonomy. We want to make sure we avoid harm, and we want to make sure that we address the concerns of both patients and caregivers. So one thing we want to very much avoid is imposing a form of menstruation management that is not necessarily what our patient themselves would feel comfortable with. There is sometimes an impetus to say, well, let's just put an IUD in our patient, make sure they're under anesthesia. That may not actually be what the patient would want. So we need to take their wants into consideration. We also have to take into consideration patient-specific factors. Do they have the ability to physically manage certain forms of contraception? Do they have the ability to physically maintain the appropriate hygiene, for instance, changing out pads or tampons? And in some cases, patients perhaps with severe or profound intellectual disability, we may want to consider menstrual suppression, particularly if that patient needs to have 100% care from the caregiver. But it is so important that decision-making capacity is recognized by not just the physician, but also the caregiver. do not assume that your patient does not have decision-making capacity. Even patients that are nonverbal does not necessarily mean that they are unable to make decisions. Please make sure that if any decisions are made, it is made with taking that particular aspect into consideration. When it comes to menstrual management and contraception, there are a number of options that are out there. And what I would hope to do right now is to go through each of these various options just to make sure that we take into consideration the specific needs of our community in terms of potential comorbidities, potential problems that we may face. For example, seizure disorders, they are very commonly comorbid with our patients with IDD. And so we need to be aware that oral contraceptives can be less effective in the presence of anti-seizure medications. Also, anti-seizure medications may be rendered less effective by contraceptives. So that is something to bear in mind. Combined oral contraceptives will require daily dosing. So the question is our patient able to maintain daily medication dosing on their own? Are they able to do it with the help of caregivers? And are they able to swallow appropriately? If some patients have decreased swallow function, this is not a good choice for them. They may use hormonal patches. So hormonal patches only require weekly administration. However, many of our patients with IDD also have a tendency to be skin pickers. So this may not be a good choice for them if they're going to constantly worry away at the patches. In addition to that, the patches may cause some skin sensitivity. So we should be cognizant of all of these issues. The vaginal ring is an excellent option for trying to avoid systemic hormonal side effects. However, the vaginal ring does require some manual dexterity, and if it is not something that a patient is able to do for themselves, it's a bit awkward to have a caregiver place a vaginal ring once a month. So that's something to consider. And then we have our longer-term reversible contraceptives. For instance, the Depo-Provera shot, which we administer once every 3 months. This is an excellent option for maintaining menstrual suppression for many of our patients, although some patients do have irregular bleeding. However, it is also associated with an average of 10 pounds weight gain over 2 years and can lead to decreased bone density. So when we have patients with IDD, frequently they're on many medications that also cause them to have weight gain, and that is something to take into consideration. In addition, many of them, unfortunately, are not as active as we would like, and so giving them a medication that can decrease their bone density is going to exacerbate problems of osteoporosis. So this is not necessarily the best option for all of our patients. In terms of the Nexplanon implant, which is the etonogestrel implant that is placed in the arm, that provides menstruation management and contraception for up to 3 years. It is very easily tolerated by most patients. However, in some patients, it does cause prolonged and irregular bleeding. If we're looking for menstrual suppression, this may potentially be the wrong choice. And then finally, we have the hormonal IUDs and the non-hormonal IUDs. Non-hormonal IUDs are good for contraceptive purposes for up to 10 years, but they do not provide any level of menstrual suppression. The hormonal IUDs are good for up to 8 years. However, they will require a pelvic examination. So this is something that we have to make sure our patient is willing and able to do. If this is the desired form of contraception, does our patient need to be sedated for this procedure? Is that something that they would consent to? So many of these various forms of menstruation management and hormonal contraception are excellent, but it needs to be very, very specific in terms of which ones we choose for each individual patient. Another area of discussion which we touched on previously is social sexual behavior. So again, all human beings have normal sexual urges. However, when you combine normal sexual urges with a lack of education, we are going to have socially unacceptable behavior. This is a great disadvantage to many of our patients because it leads to social isolation, lack of social opportunities, and social isolation for anybody leads to poorer quality of life and poorer health. So discuss with your patients about their anatomy, discuss where and when behavior is appropriate, and then talk to the coaches that are available. Again, as a reiteration, the Lowdown podcast, the Down Syndrome Resource Foundation, your local Down Syndrome Association, and Project Shine. These are all excellent resources that are available to the general public and can help put you in touch with sexual health coaches. For patients who are interested in developing relationships, it is very, very important that we discuss the hierarchy of relationships. For example, we have ourselves in the center, we have our nearest and dearest around us, we have acquaintances, and then we have strangers. And where do intimate relationships fall? Where are intimate relationships appropriate? Have that discussion with your patients. And make sure that we are screening our patients for sexual abuse. Unfortunately, patients with IDD are amongst the highest population to experience sexual abuse, and it frequently occurs with caregivers. We should be cognizant of when a patient is exhibiting unusual behavior that may indicate that they have undergone sexually inappropriate contact. We need to be able to discuss with them about various forms of sexual activity. We need to be able to discuss with them about appropriate condom usage and, again, contraception usage. We need to incorporate discussions about preferences for sexual partners. Again, patients may be homosexual, bisexual, they may be transgender. We need to be able to recognize and allow patients to comfortably have a conversation about all of these topics. And then if the patients are sexually active, we need to feel comfortable asking them specifics about the type of sexual activity so we can appropriately screen them for sexually transmitted infections. One of the most difficult things that a practitioner sometimes faces in terms of providing quality sexual health care for our IDD population is the pelvic exam for women. This is not something that a patient may necessarily feel comfortable with, and we may have to spend some time coaching them on what to expect. Utmost importance is patient comfort. Pelvic exams should never occur forced, and it should never be assumed that they need to be done under anesthesia. However, ultimately, in some cases, if a pelvic exam is necessary for health purposes and there is no other way to appropriately get that examination, anesthesia may be appropriate. We would try and work as much as we can to avoid that option if possible. So a thorough discussion, possibly using diagrams. Sometimes it takes multiple visits in which we gauge the patient's level of comfort, and having the patients for that is appropriate. Making sure that patient bed heights can be adjusted appropriately if they need to transfer from a wheelchair. And then if for some reason the patient is uncomfortable, being willing to stop the examination at that point. So I cannot reiterate this enough. Patient pelvic exams should not be forced. The last thing I want to talk about has more specifically to do with specific genetic syndromes and the type of sexual health problems or screenings that may occur with those syndromes. A majority of these have to do with patients having decreased fertility, decreased menstruation. Some of them involve hypogonadism, but these are all things that the provider needs to have some level of awareness for. It is not intended that this needs to be memorized by the provider. However, you should know that there are resources out there. So the American College of Obstetrics and Gynecology has a good website of a number of different genetic syndromes and their implications. To go over a few of them. Down syndrome specifically You will find patients frequently exhibit abnormal uterine bleeding, premenstrual dysphoric disorder. They also strongly recommend that patients with Down syndrome undergo routine testicular cancer screening, which is different than our regular population without IDD. And then our patients with Down syndrome actually are routinely not recommended to undergo breast cancer screenings. Patients with Fragile X experience ovarian insufficiency or subfertility, and they may also undergo precocious puberty. Patients with neurofibromatosis type 1 often will experience breast cancer at an early age, and they may either have delayed or precocious puberty. Patients with Prader-Willi disorder will exhibit hypogonadotropic hypogonadism and delayed puberty. They may have primary amenorrhea, and then due to that also have osteoporosis or osteopenia. Patients with Sotos syndrome, which is an abnormality of growth factor, will often exhibit ovarian fibromas. Patients with Turner syndrome will see delayed puberty, primary amenorrhea, ovarian insufficiency due to the streak ovaries, and then again, as a result, will experience osteoporosis or low bone density. So we have a list that you can see of various genetic syndromes and the types of problems that they may experience or exhibit. Our job as clinicians is to have an awareness of this, make appropriate referrals as necessary, and treat to minimize any potential long-term side effects such as osteoporosis.